Thank you, everyone, for being here for another segment of Unite to Heal. It means a lot that you come out and watch and learn about all these fascinating things that are going on. Tonight, we have two really amazing people with us, Lieba, Kobernick, and Shaya Hecht, two amazing professionals who are going to talk about the way they work with clients. So many of our clients are, so many people out there are searching for answers for healing. And I felt it was important to bring to our audience two different views, two different modalities, one could say, but with one very strong mission of helping people find healing and find peace. So with that, I'm going to ask Lieba first, if you could introduce yourself, what you do, and then we'll have Shaya do the same.
I'm Dr. Lieba Kobernick. I'm a clinical psychologist. I'm founder and director at the CBT-DBT Center, which is a group therapy practice specializing in evidence-based practices for the frum community. We do a lot of DBT, but we also do a lot of other evidence-based modalities for all kinds of problems that people struggle with. And I'm also founder of the Therapy Should Work Project, which is a community project aimed at helping change attitudes in the community towards evidence-based practice and mental health care.
Thank you. Okay. We're going to have you explain some of those letters that you said before CBT, DBT, but thank you. Shaya?
I'm Shaya Hecht. I'm a clinical social worker working on my doctorate sometime soon, hopefully.
Ditto. It's great having you in class together.
I have a group practice in the New York area where we deal with all kinds of issues, challenges, diagnoses, including trauma, and I'm sure we'll cover some of that here. And I'm also an assistant clinical professor at the Wurtzweiler School of Social Work in the Schneider program, which is a real honor to be able to teach students from the ground up some of these ideas.
Yeah.
I feel like I wish I would have had such a robust type of education, and I think that's about it. I'm a dude. I'm a human.
Love that. The human factor. That's fantastic. So, Shaya, we'll start with you. Maybe you could share with us your core worldview or philosophy that guides your clinical work.
Okay. So thank you. First of all, can I just say it's a real honor to be here. My work is really grounded in a belief, a philosophy that what we call symptoms are almost always survival adaptations, which are brilliant ways that the nervous system learns to stay alive in unsafe or unpredictable, overwhelming relationships. So I don't see trauma or mental health or even what's often labeled as BPD or CPTSD. If we could get into that, can we start talking about that a little bit?
Sure.
As lifelong defects or disorders, I see them as patterns. Patterns, nervous system adaptations that can be rewired when the body finally experiences real safety.
That's great. Let's hear Lieba's view.
I would say my philosophy is heavily informed by what's called evidence-based practice, as I already said, but to translate what that means, it means three things. It means up-to-date science in the area the person's struggling with. It means clinician experience, and it means client preference. So I guess the way I think about that practically, or what that means, is compassion, true compassion for what a person is truly struggling with. In DBT, we use the phrase, and that's my favorite phrase, phenomenological empathy. What that means is really understanding why a person is struggling with what they're struggling with, and then being completely empathic toward the problems that show up in every interaction because of those things that they're struggling with. That makes perfect sense that you're going to talk to me this way or struggle with this thing because of the things that are bringing you to this work in the first place. So that, coupled together with real scientific honesty of what we know, what we don't know about what actually helps people get better. I definitely use more of what's called a behavioral lens. So I think about how responses or things that people are struggling with have developed over time based on our learning, because we're all constantly learning beings from, I would say, from conception till death. We are learning beings. And so everything is informing how we get to where we are. And so thinking about problems from that perspective. And let's say that's like a nutshell. I have a lot more to say to that. I'll leave.
Okay, good. So, and I asked this question because, very much informed by my work at Amudim, trying to help people find the right therapist. It said therapy should work. That's one of your projects. And I think, Shaya might not have a program called Therapy Should Work, but definitely I know enough to know that he's a big believer in that as well. Therapy should work.
This is called Hecht counseling, which stands for humanly as possible, which someone told me I should change healing as possible. So we're on the same page.
Right, exactly. Nice, I like that. So is it possible for both of you to describe to me what is your ideal client and what kind of struggles do you find your work, what you do, your approach, your philosophical view of things is best suited to work with?
I'll jump in.
Please.
So my heavy training and expertise is really in a treatment called DBT, which is geared for people who are struggling with emotion regulation or managing emotions as the core issue. So there could be a whole host of kinds of issues that relate to that, but the core problem is management of emotions. And so that's really where my expertise is. Together with that, I end up working a lot with family members. I work a lot with parents who have a young adult who's struggling, or a young adult who's not getting things moving in their lives, a child who has OCD or things like that. And then I work also a lot with other kinds of issues, a lot of OCD, PTSD, and other kinds of issues people struggle with. But I find like a big unifying factor is that people who have been in therapy for a long time for maybe more serious mental health problems without really getting the kind of results they're looking for or getting really the kind of meaningful improvements that they're looking for. And I like to think that even though I'm working out very often with people who are come in with very big struggles, they're often very motivated for things to be different. And that gives me a lot of chizuk and helps me to be motivated for what we do, because I love helping people who want to get better.
Mm-hmm. So is that motivation like intrinsic to the process? Does it, or could it work without it?
That's what I love that question. So I always say, I need this much commitment and willingness, like this much. I can work with that. We can build that out into so much. I'm basically using what's called like motivational interviewing and commitment strategies from DBT, but we can build on that. If like someone won't get into the session, you can't force your teenager who has no interest. That doesn't help anybody. Bribing them into therapy, not going to help anybody. But anybody who has like any iota of I want things to be different, we can work with that. That's fine.
Nice. Shaya, tell us what does your ideal client kind of look like, and who would be like the right referral?
Yeah. So I have like these thoughts in my head, and then as I hear Chaya talking, like, ooh, it's like still rough. I hope I get it all in. So basically, I work best, I think, with, or not I work best, but my ideal client would be somebody who has a complex presentation, right? Complex trauma, we can call it. Chronic shame, dissociation, attachment injuries. That's personally what speaks to me and my work at this point. I also used to do a lot of what Lieba does. I came from that world actually, and evolved and came to this somehow. But basically, so those clients who are coming in often have very challenging attachment wounds, and they may be manifesting in their relationships in multiple ways, which I'm sure we'll talk about throughout this talk here. But one of those ways might be even in therapy, where have very challenging therapy relationships as well. So that's another way, and that makes a lot of sense. That would mirror some of their relationships. So there might be a lot of intensity in the emotion, whether it's like hyperarousal, which is hypervigilance and that type of presentation, or even the hypoaroused, where they're shut down or frozen or dissociated or something like that, which oftentimes is very scary, I guess, for a clinician to be across from, especially if we're trained in talk therapy or something like that. When a client's kind of showing up that way, you're just like, what am I going to do with this person if they're not giving me?
And just clarify the hypoarousal for the people who are familiar. what that looks like.
Thank you. So there's a term, the window of tolerance. So let's just call it window of tolerance, however big that is, which is in a person's nervous system, right? And so that's what we can't tolerate. So when we're regulated, right, we're in that window. When we're up, we're either going to go above that window or below that window when we're dysregulated. So we might be hyper aroused, which you might be familiar with, fight or flight, which is fighting off the threat or running away from the threat. That's one way that someone can present when they're feeling threatened. And another way is through freeze, which is the hypoaroused, like frozen, shut down, dissociated, disconnected. So those are really everyone, all of us have that in our lives somewhere when we're under threat, right? So we're gonna turn to something like that. So the clients that I'm seeing are the ones who are threatened by relationship itself. Because they've been hurt in a relationship, they're threatened by a relationship. So when they come into the therapy relationship, that's going to be another relationship that feels threatening. So they will most likely present in one of these ways, but they don't actually see that it can be different, meaning it's their normal, like it's chronic, it's the way that they've been living, and that there's something else that's possible doesn't really make sense to them. And oftentimes they don't even know what's wrong with them. Like they can't tell you a symptom necessarily. Like like when the classic therapy question, like, what brings you in today? They're kind of just like sitting there like, I don't know, right? Sometimes they're anxious and stressed and, or they're push and pull in relationships and they're aware, or someone in their family is aware or something. But sometimes they're just like, I don't feel right. I don't know. People say I should come here, and they're just not exactly sure how you're going to help them, if you can help them, what help even looks like, because this is just how they've pretty much been. So, yeah, that's the complicated, complex presentation. So I guess that's the client right there.
Right. Complicated and complex. So I'm wondering, Lieba, when you were describing somebody who needs help with managing their emotions, does it include the hypo and the hyper arousal? Does it include fight, flight, and freeze? Does it look at it from, or just somebody who, let's say, is acting out, like there's more of just the hyper arousal?
So I guess I don't conceptualize it that way. Think about emotion more like, let's say, 0 to 100, and there's a few different categories of how emotions work. So category of emotions called anger. There's a category of sadness, and this is basically how they work. And so we want clients learning about those different categories. But yes, some clients, and side note, a lot of clients who struggle with these kinds of issues will also have dissociation, which is kind of like disconnecting from yourself. So I'm not sure if that's what you're referring to, but yes, a lot of clients I work with struggle with dissociation or feeling kind of like numbed out and
yes.
flat. There's also another common issue with DBT clients, or that clients struggle with, either numbing out, either like everything's fine. Let's say we'll call this like everything's fine kind of model, like everything's fine, I've got this, I'm being skillful, I know how to do this, I'm okay, versus I'm in crisis, and there's very little in between. So maybe that's what you're referring to, but yes, we definitely want, and that's, I guess, where like mindfulness becomes so critical in DBT, is starting to learn how to notice what is happening, when, what moves from where, and really learning also like what I would call like self-validation, or like it's okay that I feel different things, and I can acknowledge a 10 and a 27 and a 63. And that can all be okay. It's not just 0 and 100. And this is very common for people who come to DBT, because very often they've gotten messaging that that the way you experience emotions is not normal. And so they basically learn how to shut it off, or that becomes impossible. And then there's this explosion, which can look a lot of different ways. But it's hard to learn to be with the 47, it's hard to learn to be with that. So learning more, safety around experiencing emotions, which oftentimes we're not doing until a little bit further into treatment, depending on what the person's starting with. But at some point in treatment, yes, we do want people learning how to sit with a 47. That's again, depending on where you start from, is going to be how quickly that's going to happen. But yes, what we call like emotional experiencing is really critical. And so I think that's what you're referring to.
Yeah. Yeah. I think, we all know that in the schools of psychology, excuse me, the schools of psychology and different treatment modalities will often talk about the same thing, but have different, there's like a different vernacular around each school of thought. But I think this is a very good segue, though, to ask each of you, like, what are the psychological principles or mechanisms of change that are at the heart of what you do? You know what I'm saying? So I think that based on what you're both talking about, like, we could start hearing what's the process? You know what I'm saying? What makes the magic, or to say it differently, what's the secret sauce? Shaya?
So, Myriam, I'll be honest with you, I'm still trying to figure this one out. It's still evolving for me, but I do have some ideas that are speaking to me as of today. So I have the right to change that, because I think I've been humbled enough to realize that there's so much that I don't understand. Like really, there's just something about humanity that I will forever try to understand, but I don't know if I ever will pin it down to what it is. But for me, because like the things that Chaya and Lieba are talking about, like the intense emotional experiences and things like that, and the messaging that they're not good enough. So the way that I view that is like, that's a rupture. That's an attachment rupture. And since that's a rupture that happened in relationship, so the healing has to happen in a relationship, in a corrective experience, where the person's not just told like, oh, you can be 67 and that's okay. They have to feel like acceptable, right? Like, I am okay. And that's a felt sense thing that doesn't happen with words. Maybe it could. Words can help, I imagine, but it's something that they have to feel. And it's very, very tricky for it to feel that way when the relationship itself is the threat. So for me, like, yeah, so the relationship caused the wound. So now relationship needs to heal, but the relationship itself is threatening. So the amygdala, which is the part of the brain that's firing a threat, is saying to the therapist themselves, not in words, right? But in reaction, that like, this is not okay. I'm not okay. When am I going to speak to you after the sessions? Where are you going to be? What's going on? How are you going to help me? How are you helping me? I don't feel better. Whatever that is going on, or the freeze, because this actually, I've learned implicitly that this itself is not safe. So that becomes a very, very big challenge. So if we can find a way to help the person rewire this system that's firing threat for it to feel more safe, if we can find a way, which has to be in a relationship, then the person can start to like feel the safety that's automatic, right? It's just automatic. And once a person feels safe,
that might even have been like their birthright, but somehow it was taken away.
And once they're safe, they're regulated. Once they're safe, they're regulated. The reason why they're not regulated is because they're not feeling safe. And the reason why they're not feeling safe is because the relationship is threatening. And there's implicit memories that their nervous system has and learnings that they're holding on to that needs to really go back into the nervous system through relationship to provide the corrective experience, which is a very, very big challenge. And over time, through neuroplasticity and more connections, we could build new neural pathways to be able to feel like, you know what? Whew, I can be okay. Whoa, I've never felt this way before. That's unbelievable. Wait, is that safe? Because I have to be hypervigilant. The world is threatening. My relationships are threatening. I don't know who I am. I've split off from myself. We can talk about fragmentation. And this feeling doesn't feel safe either. So we're going to now, again, the amygdala is going to fire. And there's a lot that has to really be rewired in the nervous system to rebuild it to a place where they are really healing and they have this felt sense of safety and are regulated.
Thanks, Shaya. Lieba, tell us about how it works. What's the mechanism in your world, and maybe even respond to Shaya's conceptualizations.
Sure. Okay. So 2 separate questions.
Yeah.
So
with the first.
Yeah. I'm just noting for myself. Gonna get to all of it. So firstly, yeah, I love this question because to me, I think that like process of change or mechanisms of action is really like the front line of what's going on in psychological research today. So really understanding why, even 10 years ago, that's when when I think the field started to really direct attention towards, okay, we know a lot of things that help, but why do those things help? And let's really get specific about it. And now we actually do know a lot. So this is like a fascinating area to me. That said, I'll talk specifically about DBT since that's what the kind of issues that we're talking about right now. So I'll talk specifically about that. First of all, and this is more general, therapy has to be collaborative, meaning the person in therapy and the therapist have to be on the same page about what is the problem, what the person cares about, what we're moving towards. So like that's really important. And therapy should be responsive to progress. So that's like one very core thing. But more specific to these types of issues, I'll say I explained already a little bit about how behavior or behavioral theory informs the kind of work that I do. So I'll say more specifically within DBT, stability creates capacity for emotional experiencing. Let's say it that way. So when we start in DBT, we call this the house of DBT, and there's different stages of treatment. So people start in, I'll explain it this way and then back up to the processes. When people start in DBT, they're very often starting out what we call the basement. They're in stage 0. They don't know what DBT is, and they also are probably in like some level of hell, is what we call it. And they're in the basement, and there's no even commitment yet to what we're going to do. We form commitment as like our basis, and we climb up in the house, like to level 1, right? And stage 1 is where we're going to focus on building stability, behavioral control, and emotional control. And those words sound like a little harsh, but what they mean is very often people come into DBT in a level of chaos, and we can't do anything in that level of chaos. So I know there's a big debate about treating PTSD symptoms or trauma, but I'll explain my thoughts on that. Treating trauma first, because that's like the root of the issue. And DBT takes a very hard stance against that. And I think the field does. I think the PTSD researchers as well are like that. There's like some ability to do something, but the bottom line is that PTSD treatment, what we know about PTSD, again, in terms of processes, we're talking about like why what works. So PTSD is an issue of avoidance. What I mean by that is that people go through all kinds of experiences in their lives, and every reaction we have to those experiences is completely normal and understandable. I may not understand every reaction, but every reaction is normal and makes perfect sense. And when I get stuck in my reactions, that's when I develop a PTSD type of issue. So the stuckness is the problem we're trying to address. Now that stuckness has to do with avoidance of my ability to sit with what happened. Now, what happened might be horrific, and I don't know why anyone would want to sit with it, but my inability to sit with my reality is what keeps me stuck. So given that the issue that's driving the symptoms or the problem is avoidance, if my issue is the instability, right, that chaos I was talking about, that level 1, in hell kind of experience, I cannot, it is not humanly possible to sit in contact with the thing I've been avoiding while I have no ability to do that, right? That doesn't actually logically make sense. So first I have to develop the capacity to sit without running away. So we're going to be developing that first. And that's what I mean by behavioral and emotional control and stability. That's my ability to sit with. Once we are no longer self-harming, suicidal, taking drugs that aren't prescribed to us, getting into fights with my husband every day, whatever it is, once that's not happening, or even other more simple things, like I'm keeping up with a job, I'm just keeping up with my daily schedule, okay? I'm awake during waking hours, okay? So when the regular stuff is happening, now we can actually introduce capacity to sit with massively difficult emotional states and experiences, more emotional states, but I'll leave that. In terms of, I did want to also come back to the point about.
Well, I'm gonna stop you from answering question number 2. I'm just curious what Shaya, Does this sound like what somebody who's working, let's say, somatically will need to do, let's say, resourcing, grounding before they will jump into trauma work? Does that sound similar? Is it feeling familiar? It is to me. I'm wondering if it is for you.
I completely agree that a person, we can't go after, let's say, trauma memories and healing them if a person can't find some safety or stability within themselves, right? I think where I would just differentiate a little bit here is I think I'd peel it back, I think, even more. Like, I think I'm even more cautious, like a little more cautious. Because for me, I want to just differentiate PTSD and CPTSD, if that's okay. Like, Lieba is absolutely right that PTSD is all about like the avoidance of the overwhelm and the memories or the sensations, whatever. And in CPTSD, there is a much bigger nuance that we have to talk about, which is the inherent lack of safety that's felt due to a lack of connection with somebody else, right? So the trauma came from a disconnection. That's how it overwhelmed the nervous system, from disconnection. So because I was in this overwhelmed state, it was too much for my body to manage on its own. I didn't have the attachment that I needed, the co-regulation that I needed to get through that time. And therefore, I'm overwhelmed. And now my nervous system is like the wiring is kind of faulty. I don't want to use that word, but I just want to use it as a metaphor. Like kind of like the example of like the smoke detectors going off, and you can have burnt toast, in the thing, or your house on fire, and you don't know the difference. To you, it's this massive emergency because that's literally what it feels like inside, and that's chronic. Like that's my nervous system. So it comes from real chronic childhood neglect or emotional abuse or attachment ruptures over and over again, or coercive control, things like that. So that's going to affect my identity with myself. Who am I? It's gonna cause a fragmentation. There's a theory called structural dissociation where I'm literally gonna have to split off of myself in order to function and like, how am I going to survive? Like, how do I go on? How do I go to work? How do I go to school? How do I make friends when that's my nervous system? So there's these traumatized parts of me that are stuck, like as I was saying, they're stuck inside of me. They're inside of me, and they're actually still here right now because my hippocampus, which is the part of my brain that differentiates past and present and is able to organize the memories. When I was overwhelmed, it wasn't doing its job. And therefore, right now, when I'm 35 years old in therapy, I literally am 6 or 7 or 8 in my nervous system because of that's when those things started to happen. And even though you're a kind, compassionate therapist who really, truly cares and is truly safe, I don't feel that. I don't feel any of that. And I'm super overwhelmed. So for me, I need to like back it up and work on this relationship with co-regulation because they never got it or it wasn't consistent enough. So I want to get to the same place. But for me, I think I can't force that regulation, through like skills or something like that, because that doesn't feel safe. That doesn't feel safe. Clients who do that are often fawning because they need the attachment. So they just like, yep.
Explain fawning, Shaya, for people who might not know what that is.
So we have the F's of fight, flight, freeze, fawn. So fawn is a adaptation to trauma, which is in order for me to survive this very scary or overwhelming relationship that's here, I need to be what they want me to be in order to have connection. I can't survive without it, right? So if they want me to just be quiet and suppress my emotions, that's what I'm going to have to do. If they want me to take care of them, even though they're adults and I'm a child, that's what I'm going to start to do because that's the fragmentation. That's what I need to do to survive. So a little bit when a therapist is like sitting with a client and saying like, we're going to teach you regulation skills, let's say, the therapist, the client's firing in their brain, like regulation, I don't know what that is. I can't actually feel safe. I'm actually hypervigilant right now. I don't know that. But you're actually the person who is stressing me out because you're in a relationship. So I'm actually overwhelmed and feeling threatened by this whole thing. But I also need you because my life is not okay. right? So I will do whatever you say. I will try my hardest to do whatever you say to sort of get to the place where you need me to be so that my symptoms are improving or whatever, because I need connection. Ultimately, that's what I need. So that's what I'm going to do. So for me, I want to be very cautious that I'm not reenacting the fawning response and the like, I need you to be this way. You know, in order for me to work with you, you need to stop being like that or something like that, like a behavioral, you know, like, which is what really they've been through. And that was survival. I'm trying to rewire this whole thing and say, yell, scream, kick, you make sense, go for it. I got you. Let's go. Bring it out.
Great. You know? Lieba, I want to hear how.
And then,
sorry.
And that's phase one. To me, that's like a phase. So I'm like lower in the basement. I'm like the sub basement.
Right.
I'm going a little bit underneath.
You're in the McClot, like in the, you know, in the bomb shelter.
Because I can't get to the skills yet. Skills are so awesome. They really are. But the safety is not there. Like the safety is not there. So to bring the skills before the safety, it's just, for me, I need to make sure, and I think we're always going to be dancing in both, you know, somewhat. I need to start with like, okay, co-regulation. I'm going to have to be very, very regulated, which means I need to be pretty worked on because whatever's coming at me is pretty intense and also challenging the attachment, the therapeutic connection. So I have to like be really in tune with my own nervous system and really able to tolerate a lot. And then to remain that regulated presence where the client actually can feel through my social engagement, through my micro expressions in my face, through my calm, through my connection, my compassion. They could start to sense it and feel it, which will at first feel threatening, and they'll test it subconsciously, but over time they'll start to come in very, very differently. They'll feel different, which I can't necessarily measure as a symptom. You know, here, look what happened. Before they came in, they looked around the room 7 times, and this time they looked 8 times. Usually they scan where's the door and the window. This time they're not scanning where's the door and the window with the same intensity. It's very hard to like quantify it, but the client can feel a difference. I could feel a difference. Now they're like, the window of tolerance that we described is increasing. The dissociations are less intense. The testing of the relationship is slowing down, where the person has enough of a safety there, where now we could start to introduce the idea of self-regulation. Because if you think about it, the idea of self-regulation is you're on your own, right?
Right.
Which is basically the trauma that they've been through in CPTSD. Is like, go home, practice this, have a nice day, right? Or something like that, which I'm glorifying. It's obviously very compassionate, but I'm just saying it's the idea of self-regulation is scary. In the body, my body's maybe been abused. My nervous system actually needs this hypervigilance right now. And I can't like slow down. It's like telling someone who's being chased by a tiger, take some deep breaths,
Now's not the time. Right.
Yeah, I'm actually feeling threatened. So I first needed to be like that. And now, deep breaths are so helpful. Wow. You know, so there's, to me, then I'm coming up to the basin. Yeah.
Got it. Lieba, I'm curious your thoughts and how this, you know, weaves in with what you were talking about and how you hear it.
Yeah, I guess I'm not 100% sure where to start. So I'll probably bounce all over the place. But I guess my first thought is I'm not going to be working on like the kinds of things that you brought up, like whatever, and any of the things you brought up. I'm not going to want to work on those things when I have somebody in front of me who's suicidal, self-harming, active eating disorder, active substance use, or in constant crisis interpersonally. That said, we do rely extremely. Okay, forget about DBT a second. We leave the term on the side because I think people associate it too much with skills. But the way that this model is going to work, we're relying heavily on the relationship. So, for example, we have 24/7 phone coaching. That means that I'm available to you anytime you need. Now, I also am going to have a life. Like, I just texted a client right before we started this, who I know is having, whatever, we had a difficult session. We were talking a little bit about it. And I just said, like, call if you need, but my phone's going to be off for the next, while, because I'm going to be in this meeting. But that is an ongoing part of my life, is that I'm showing up for my clients whenever and wherever they need, because in the moment is when real change is going to happen. So, Yes.
Mm.
And I always say, this is also, I think, why a lot of times therapists think I'll send my client for DBT. They're self-harming, they start self-harming, I'll send them to a DBT skills group. And we always say, like, and we're not saying no, but we don't think it's going to help you, because learning skills is a nice thing. Applying them is a whole different ballgame. And not that skills is even the only tool we use. Skills is one tool that most people who are struggling with managing their emotions probably need some. I mean, I think all people could use help with learning emotion regulation skills or skills for managing emotions. But particularly if you've been struggling with managing your emotions in a big way, you're probably going to benefit from learning a bunch of skills about how to do that. But that's only one small piece of the picture. And
and this is a really important point. I'd like you to elaborate on what comprehensive DBT is.
Yeah.
I feel like people out there don't know, and something that I may have even learned from you, I'm not sure, but what is comprehensive DBT and how is that different than just learning skills?
Yeah. So comprehensive DBT, I started explaining before, I like to talk about two main things. So number one would be that house of treatment, or the stages of treatment. So we've got stage 0, which is pre-treatment, which is about orientation and commitment. Stage 1, which is about behavioral and emotional control. And then stage 2, which is about emotional experiencing and PTSD treatment. And then stage 3, which is about ordinary happiness and unhappiness, really where we're dealing with depression, anxiety, relationship issues, fine. Quality of life issues. And then stage 4, which is peak spiritual experiencing. I would say, well, my clients don't stay for that part. That's okay. They don't need to get right. But that's basically the house of DBT, or the structure of how we think about how to work with different issues. And then there's also important to know is the different modes of treatment. So most treatments include individual therapy. That's what we traditionally know about. In DBT, we have 4 modes of treatment. The first, or it's not really in order, one is individual therapy, which will very often, depending on the situation, but very often include a family component. So very often we're doing family sessions or parent sessions, depending on the situation. It also includes skills training, where we're learning skills, where we're focused just on learn skills. But individual sessions have a different focus, which is really to get a very detailed in stage 1, a very detailed understanding of why the problems that I'm experiencing are happening and what is making them happen, so that we can really target making them different. And then there's phone coaching, which is about a few different things. Number 1 is about generalizing the things that I'm learning in treatment. So if we've talked about doing something different, I'm in that moment and I want to do that thing, and it's really, really hard. So the therapist can help me with generalizing it. Usually that means that there's going to be more phone coaching earlier in treatment and less later on, but that can be different. A lot of people don't use it at all, which is a separate treatment problem, meaning we have to get them to use it more. Some people are going to use it relationally and have a lot of relational challenges, and we're going to use that to actually structure new learning relationally, of how hey, if you call me every night at 3 a.m., I'm really tired by the time I get to your session. And you don't want such a tired therapist, right? So just as a silly example, but yes, but when I get that client who has never called me once in 6 months of treatment and calls me and says, I know we talked about going to do this exposure and I'm about to do it, but and I'm able to walk them through that. And then all treatment is easier from there on out. Please call me 1:30 whenever you want. That's phone coaching. And then there's also consultation team. So DBT therapists need to be part of a team, which is intent with the main goal of therapy for the therapist. The therapists are walking in able to do adherent DBT and take care of themselves in the challenging cases that they work with. So that's the modes of DBT. Hope that explained that.
Yeah. Right. And I think it's important to put it out there. Thank you. Thank you for explaining it so comprehensively, because people really think that DBT is skills group, and it is much more than that. And it kind of explains how it could be a successful model, because it's providing so many layers of support. While the skills group is a very nice thing. I always say they should teach the skills in school. I don't know what they're waiting for, but
there is a school curriculum. There is. I don't know what the schools are.
Sure. I'm sure. Yeah. I don't know if any schools have them, but I'm sure there is a school curriculum. It would just make sense. Okay. That kind of rounds out the picture of where the treatment is really happening in these different styles and these different philosophical approaches to treating difficult situations. So I'd like to maybe tease out, what are some of the stigmas, myth around BPD, and can you speak to how do you define BPD? Is it the same as trauma? Is it different than trauma? Is there a correlation? Is there causation between one and the other? And I'd love to hear, maybe even, if you off the top of your head could speak to what the literature says about it. I think that would be really interesting for our viewers to hear.
First of all, this also lights me up, like that we're having a conversation. What's BPD? What's CPTSD? Like these labels are so challenging for our clients. Like, and the way that sometimes they're stigmatized based on their labels is just so upsetting. So the way that I think that the literature is a little bit conflicted. I'm just in my understanding, and I'm still researching this. This is actually a big topic of mine in my doctorate. There was definitely a movement that was saying that a lot of CPTS, a lot of BPD diagnosed people, borderline personality disorder, really have CPTSD, right? And really there's underlying trauma that's there. And that's what's, the root of this presentation. Mm-hmm. Now they're trying to I think they're agreeing that most people with borderline personality disorder have an underlying trauma root. I think you may find some percentage that really it's genetic or something. I don't know exactly. That's not my field, but something that's separate from trauma. But let's assume, for our argument's sake, because I think it's most people with borderline personality disorder, what they're dealing with is rooted in trauma, right? So now, if we're viewing, but what's the differentiation? So some people say, okay, so the CPTSD is more the shut down states and the identity thing, not necessarily the relational fast pace, switching, push pull as much. But that's just in the way that it might present itself. But underneath it, it's going to be the trauma. So if we're viewing it so to me, it's almost unimportant what name we give this thing, because if we're viewing this as it actually is important, because we might give it the wrong name and the wrong connotation. So if we're viewing this as rooted in trauma, then it's not a personality. It's not something that you're going to deal with now for the rest of your life, and you're just going to have to cope with it. I think there maybe is a view like that out there, right? And I don't subscribe to that. To me, it's your nervous system's wired a certain way. I could probably link your label of borderline personality disorder to disorganized attachment style, which is a push and pull in the relationship. And if we go back to your history, we'll probably find that your caregivers were very scary to some degree, and you were craving connection, and also
very scary to you, right?
Very scary to you in your perception.
Right.
Absolutely. So for you were craving connection, and you're also terrified of it at the same time. So there's this they call it disorganized, right? Or fearful avoidance. It's push and it's pull. And what you'll see in borderline personality disorder is really, if you want to put it in trauma terms, it's a switch between the hypo-aroused states and the hyper-aroused states, right? Mm-hmm. I'm disconnecting, I'm connecting, I'm clinging, I'm disconnecting, right? So we have that push and the pull and the push and the pull. So why that's happening is from a trauma root, which is an attachment trauma root, not PTSD, right? But CPTSD. Then what we need to do is heal this through relationship, and then the system will feel safe, and the system will regulate itself. Because we don't teach babies any skills. We take them out of their cribs, we put them here, and they're okay, right? So if this person had ruptures that wired it differently, so now we have to do that again, and we have to go back there, do that co-regulation, and the system will start to feel safe, and regulation's just going to happen, just like that. So for me, that's so hopeful, right? We don't need it's not a bad behavior. It's not, you're misbehaving. Something's wrong with you. I think I was saying before as well. That's not what we're talking about. This is a survival adaptation. This is the way your system does it. And now we'll provide the co-regulation and the healing in the relationship, and you'll be good to go.
So CPTSD or PTSD behaviors, completely healable. It may take a while, whatever, but this is not.
Let's rewire the nervous system. Now, I don't like the destination cold healed. Like, I'm not into that. I don't know what that is.
No, it's always about the journey.
I don't know exactly what that is, but we're building capacity. We're building capacity, okay, in the world. We're building my relationship with myself is better. My relationship with the people around me is better. My relationship with God is better. Everything just falls into place like naturally. I don't have to address these things necessarily directly to get that result. It's through the process of just feeling more safe, just through that co-regulation and that relational piece. And that starts to develop and regulation shows up. And can I just say one more piece of it? Lately the word dysregulation is bothering me. Like, I just have to put it, because it's pathologizing. Like, it's the lack of regulation. Like, you're doing something wrong. It's like I'm disapproving. It's like you're dysregulated. Your nervous system's naturally dysregulated to survive. You went into dysregulation means I'm hypoaroused or I'm hyperaroused, right? Or I'm going back and forth between both. So in relationship, how could you be in a relationship and go back and forth between both and feel okay, and the people around you don't feel okay with you, right? But there's nothing wrong with you. You're just surviving through what we're calling dysregulation, which really is the way that you survived. And now we're going to teach you that there's such a thing as regulation, which is not calm. That's not what regulation means. Regulation means we can be with emotional experience, a range of experience, a range of intensity. All of that is going to be okay when we could increase the window of tolerance through that relational piece.
That's nice. That's a very compassionate, beautiful view. Thank you. Lieba, you're on.
Like, a million things to say, so
go for it. Jump.
I'm trying to fix my brain. The first thing I want to say is that borderline personality disorder is one of the most one of the disorders that people recover them at the highest rate from. So, like, different research.
So that myth is false. I would like to put it out there.
False. We know at least 80% of people with a diagnosis of borderline personality disorder within 10 years will no longer have that diagnosis, like, will no longer meet criteria. At least. Number one. Number two.
I wish we had like a studio audience so everyone would have just clapped. You know what I mean? Like, we don't have that here with Zoom. That's a big deal to hear. Yeah.
It is. The whole system of diagnostic categories has to do with the fact that we're operating within a certain model. Like, listen, it's not a good system. It is a bad system. It is a flawed system. It is not a system that helps us to treat from a functional perspective. Everybody will acknowledge that. The reason we had to create it is because, yes, medication trials, yes, treatment trials, yes, insurance companies, yes, funding, yes, grants, yes, this is how the field had to develop, unless you had a better idea. But, like, that's how it had to work. We have to be able to discriminate and come up with diagnostic categories in order to develop these things. That said, nobody really, I don't think, should be treating from a diagnostic model. Most people would agree it's an oversimplified approach that doesn't address function. So we need to be addressing function. I don't ever use the term borderline personality disorder unless my client is bringing it up because they've been told this by other people or other places. So I'm not even talking about that in the first place. What we talk about is a biological emotional sensitivity that lots of people are born with. Probably majority of therapists are biologically emotionally sensitive, let's be honest. So biological emotional sensitivity, not a problem. Some people are just more emotionally sensitive. Some people are more sound sensitive. They can pick up on nuances in music much easier. No one's pathologizing that, right? There's nothing wrong with being biologically emotionally sensitive. However, if you are biologically emotionally sensitive, you might get into some trouble when you experience the world, which is true of everybody who's different in any way, shape, or form. But if you're going to experience the world through your emotional lens, and the people around you are going to be like, what is wrong with you? That is going to be very confusing. Now, it can be neglect, abuse, terrible, horrible things, but it also can just be as simple as getting a constant message of emotions are unsafe to feel. You can't really interpret them or understand your emotions, and anything you try to do about them doesn't work. So you should just try to shut it out as best you can, and you're going to fail a lot because you're emotionally sensitive, and you're going to hate yourself for it. And that's a really bad cycle to be in, and often leads to a pattern of instability and difficulty with regulating emotions. I'll use that term again just to talk about the topic of difficulty with managing, controlling my own emotions. Okay, or like emotions kind of running the show instead of me and my own, we call them DBT, like my wise-minded capacity running the show. Fine. I want to also say many people with all kinds of mental health conditions have a trauma history. People with psychosis often have a trauma history. People with bipolar disorder often have a trauma history. People with social anxiety can have a trauma history. People with OCD can have a trauma history. So saying that trauma is at the root is really, I think, and here's why I'll get like really upset, is the most stigmatizing and destructive thing that we could do to this community of people is by saying that it's kosher if you went through a classified, prescribed, diagnosed, mood. Went through a classified, diagnosed, physician approved trauma, then your symptoms are now kosher. And if not, then it must be a personality disorder, genetic, whatever, your fault kind of thing. That you're going to have this personality endlessly, and it's something to do with you, and probably your spouse should divorce you too. I get this all the time. If it's just personality, like what are we supposed to do? And so they'll go to all these diagnosticians to get feedback, and then go to the rub to be told that if she really has, then therefore, this is total nonsense. That's fueled by this belief that if there's this underlying trauma, then all of a sudden, I remember having a conversation with a therapist who sent me a client. It was a spouse of their client, because they believed that they had borderline personality disorder. And when I spoke with the therapist after meeting the client a few times, and I started to explain about my conceptualization, they said, "Oh, so you're saying it's trauma?" I wanted to hang up the phone. I was so like, and if it wouldn't have been past learning experiences, which it always is past learning experiences, because our learning shapes everything that we do. If it wouldn't have been past learning experiences, then what would you have told your client? Then what? Then she's bad? That's insane. That's insane, and that's not a service to anybody. Now, so we back up on the actual thing that we're looking at here. Borderline personality disorder, whatever you want to call it. Yes, it's a problem. And already years ago, they've been trying to remove this personality, whatever categorization, and they haven't come up with a good consensus yet. Fine, granted, it's a problem. Okay, the labeling is old, outdated. It doesn't capture what we're talking about. But the diagnostic category holds. Now, when we look at current research on CPTSD, which is, just to clarify for people, CPTSD stands for complex PTSD, or complex post-traumatic stress disorder, and it's a diagnosis that's been included in the ICD-11, which is the diagnostic manual for Europe, predominantly, and it's not been included in the DSM, which is the diagnostic manual for America. The research that exists today, as far as I'm aware, is that yes, we can use statistics to separate out these two categories of people to some degree with minor differences, but we can separate them out. But that does not translate into any differences in what's helpful in treatment. As far as the research is today, it's all obviously very new because it's a new diagnostic category, but there's not been established that a unique treatment category is needed. The only thing that's been established is things that actually repeat what we already know. So either traditional PTSD treatments like prolonged exposure or cognitive processing therapy, taking maybe a little longer for treatment, but the same approach, or a phased approach like how DBT does it with like establishment of like skills and affect regulation, and then a PTSD component, which is exactly what we talked about already. My biggest issue with the diagnosis, my biggest issue, and I already hinted at this, is that it is way too validating. Way too validating. I will not tell you the number of people come to me and said, "Oh, I was told that it's actually CPTSD. Now I'm good. Now I don't actually have to work on these things because it's my CPTSD. So now I have to," and basically the mindset is, now I'm going to be in endless trauma treatment to treat my trauma, which, just to also clarify, you can't treat trauma because trauma is an experience or set of experiences. It happened. I'm sorry it happened. I'm very sorry it happened. It's terrible that it happened. It shouldn't have happened. You can't make it not have happened. You can only treat the things that you're struggling with now as a result of what happened, which can look different for every single person. And you may fit in this group of people who present with this set of symptoms versus this. And guess what? None of us are so massively unique that we're going to present with something so crazy that nobody else has, even though it can feel that way at times. You're going to, respond in some ways that are similar to other people. Feel that that's okay. It's okay that your responses are your responses. Like you're normal in your responses, but deal with the responses instead of getting hooked on, well, it was trauma, therefore what? So that's where I get because it's way too validating. It massively further stigmatizes BPD and borderline personality disorder. It massively further stigmatizes that category and makes it that therefore I'm only kosher as long as I stay traumatized. I have to stay ill to justify my symptoms. And if I don't stay ill, then the perpetrator was okay. The person who harmed me was okay. And it's my fault for struggling. That's where people get really, really stuck. And I don't see that people really start to get towards the lives that they're looking to get to. So
you're saying that people are comfortable owning the trauma diagnosis because it gives them permission or leeway or gets the rabbi off their back or something like that.
It's very like manipulative and intentional. I would say people like it because not people like it. Like, don't you want to be told that your symptoms are not your fault instead of a pathologizing model that says that your symptoms are your fault? Of course. And nobody's symptoms are their fault. We're all a result of our experiences, and we're all struggling with whatever we're struggling with because of us, because of the lives that we've had and the situations and how we've responded to it. But that's not about fault. It's all normal. It all makes sense. And if you want to get better from that, if you want to lead a healthier life or a life that's more aligned with who you want to be, you have to own that. And that's really hard to own if the only way you can justify the struggles that you've had is because of your trauma. That is very sticking.
I'm curious, Shaya, how do you hear that, and how does that mesh with?
I don't understand what I'm missing because I love the passion here, but I'm not getting it. I'm sorry. So why would someone want to say that they were traumatized? I think that's who wants to say that they have trauma? In my experience, most people don't want to have trauma. They want to be okay. So like I must be missing something. I'm not getting it.
Right. Yeah. Now, in my experience, people want to say that the reason that they're struggling with the things that they're struggling with are because of somebody else, because of the things that have happened to me. I'm like, they happened to me, so I can't control it, versus your problems are your fault. Like, get your act together. Why are you behaving this way? Or why are you this?
So a trauma diagnosis says this, you are like this because this happened to you. And a BPD diagnosis says you were born this way. It's your genetic makeup. So it's your fault. There's more
I'm not
for
hearing
some people.
How is that your fault if you were born this way? I'm not getting that.
Not that it's not that it's your
the
fault.
Social stigma, I think, is what I was talking about.
Like, there's something inherently wrong about you. There's something inherently about you that's wrong.
Right. So we both agree there's nothing inherently wrong with you. That we both agree on?
Yes.
We both agree that the reason why a person can be presenting with these symptoms is because they've been through a trauma. We both agree on that? And you'll say everyone. Okay, but I'm saying someone who's presenting this way, we both agree on that. So where are we disagreeing? That's what I'm not getting.
I don't know.
You've been agreeing? Okay, I thought we were disagreeing. So
Sorry, this is such an agreeable debate.
No, I thought I heard you say that.
No, I think the point that Chaya Lieba might be bringing up, and correct me if I'm wrong, is that perhaps there is a leaning in the clinical world, in the therapeutic world, maybe even specifically in the frum community, but I'm not sure if you were implying that trauma, good. So meaning not that it's good to have to be traumatized or to have trauma, but that's okay. We get it. We'll support you through that. But if it's just if we look at it just through the lens of BPD, then yeah.
That is not my experience at all in the frum world with
Right.
trauma. Trauma is not something that we embrace. Trauma is something that we do not deal with. Trauma is out of this society itself. doesn't deal with trauma. So I don't have this experience. In the front world, we just want to say we all have trauma, and then everyone's so accepting. I find it to be the exact opposite, actually. Like, your trauma, I can't deal with you. That's crazy making, and you're just damaged goods. That's been my experience. That's why maybe I wasn't relating to this conversation so well.
Right. I think so. It's just interesting, and I think it's really worth highlighting. I'm taking notes as you're speaking with my little red pen, and some in blue and some in green. But I think that what's fascinating, what's coming out from this conversation, that Chaya Lieba and Shaya both have the experience of clients coming in, or Chaya Lieba seeing it indirectly through the collaterals around the client's life, who are stigmatizing them. Chaya Lieba's experience might be like, oh, if it was packaged in trauma, then maybe it would be kosher. But Shaya is saying those packaged in trauma are also being stigmatized. Here we are, two clinicians coming at it from very different points of view, and are in pain because their clients are being marginalized.
Yeah.
And I think that is a very eye-opening and profound realization that we all have to look at, and hopefully the people listening, outside, however many people will be listening to watching this, will recognize, be mindful. People are a byproduct of their experiences. Nothing wrong with them. Give them a chance. Don't stigmatize. We're all a byproduct of our learning, of our experiences.
Yeah. I hope there's a day that Klal Yisrael says, "Oh, trauma, you make sense. Come to my house, come to my table, come marry into my family. Mm-hmm. It's not your fault, that your family had to just have a marriage dissolve because somebody did some terrible things there. It's okay that there's a single family now. That's going to be fine with us." I hope we could take a moment to just pray, like really pray, that our community is at that point. That sounds amazing. That is totally not where we're at. Like, totally not.
Definitely not from the experience of our clients who are coming in and sharing their experience.
Lieba, do you opposite messages that it is their fault that it's like this, and they're the problem, and absolutely.
Mm-hmm. Yeah. Lieba, thoughts?
I hear what you're saying. I'm not saying that every person who grew up with a divorced family is going to have the easiest time in shidduchim, depending on a million other factors. But I do think that there's a very big world of difference between a person having an active mental health disorder versus a person identifying as somebody who's been through a traumatic experience.
Mm-hmm. Mm-hmm. Right. And again, I think what we're both hearing is that both of those people are feeling marginalized. And yeah, I'd like to hear a little bit more, Chaya Lieba, about this conceptualization of seeing trauma, over validating trauma. I'm wondering if you can give us maybe even a case example of how that played out clinically, because one of the things that we do is we validate, at least clinically, clinicians are going to validate people's experience. So this idea of over-validation, I want to hear a little bit more so that people out there, and maybe we could talk about, could hear about it, and we could talk about it a little bit more. Validation is key until that safety is experienced. So where does the over-validation come in?
Yeah. So the person I'm thinking of did not meet criteria for PTSD, did not actually need, from my perspective, any kind of PTSD-focused treatment. They came in with some emotion dysregulation and some OCD. And we started with this frame of like, let's establish some more stability. Now, as we started doing that, past therapy experiences kept getting raised of like, well, the reason I struggle with that is because, my mother and then the story. And what I kept redirecting for at that stage was like, okay, like we'll get there, but now let's focus on what you want to focus on first. Like let's get that down, because she was really motivated to work towards the OCD stuff. So we worked on that. That got down within, let's say, like 3 months, I would say. And then we were able to focus on the OCD stuff, which I would say maybe was another 3 to 6 months. And that really calmed down as well. Once those things calmed down, that's when more of the like, well, the reason I have this is because my mother did these crazy things, because my father, and the language around it was so awful. A lot of, and what I mean by that is that the language was very, I call it, and this is how I explain it to clients, non-specific and likely to make you more upset and more stuck. So the way that we often talk about issues, like he was so narcissistic, you won't believe, like I can tell you 100 examples how my father prioritized himself. He's so narcissistic. He's like a terrible person. I don't want my kids to be exposed to that. Let's say language like that. That leaves you very stuck and very unable to figure out to actually work towards the things that you've been starting to tell me about, which is that you want to figure out how to handle an adult relationship with your parents and your siblings, given the things that have happened. I want to help you figure that stuff out. It's going to be really, really hard to do if you keep on thinking of them in these terms, because there's so much anger to this storyline that's going to keep you very miserable. Mm. And then could tell a lot of stories about how terrible her mother was. And what we have to stop with each story and each example is, that's awful. I'm so sorry your mother did that. That's terrible. And like that, therefore what? And that happened. But if you keep talking to yourself in this story, in this way, in this kind of language of talking about like she's like so unstable, she's so unwell, there's something seriously sick about her. When you keep talking that way in your head, you are going to feel a lot of intense emotions about that, because it's language that fuels that emotional response. It's not happening right now. And you get to, as an adult who's not going through that right now, decide based on what's actually going on right now, what you want to do about that. And the client did eventually get to a place where she was able to decide, okay, this is who my parents are, and this is how I feel about the past. And I therefore want to do X, Y, Z. And that can also change. I can change about those feelings, right? I can get new information. We could do a Shabbos together, and I could be like, okay, that is not acceptable. I'm going to now say something, or I'm going to not invite them back for, or whatever it's going to be, right? I can decide what I want to do about that, but I am not trapped by, and the reason I'm bringing up that, the reason that case came up to my mind was because I could see this easily have going the direction of, and I think that is what she had historically experienced in other therapy experiences based on what she had shared with me, that there was a lot of air given to, air, I mean like a lot of like space in treatment given to like working through all these stories of how horrible her parents had been. And so there was a lot, like when we first started working together, she would use words like they were abusive, they were crazy, they're really sick people, they're clearly mentally ill. And that kind of language, like by the end of the first year of working together, that was a completely different, my father will like parent my kids, and in a way that is like dismissive, and I don't want my kids hearing that. And so I'm going to either like try to explain to him why that's not okay, and if that's not going to work, then we're going to have to limit that. Great, you can do that. You can do that, and you can like step into owning that you want to do that. You want to try to have this relationship, and you're aware of things that are not acceptable to you. Perfect. But we were able to focus on the treatment that actually moved her forward in her own goals and her own things that she wanted in her life, that didn't get distracted by the over validation of the trauma. Okay. I've seen that just so many times. So I'll leave that story captured it.
Yeah. Right. Okay. That definitely paints a picture.
Let's talk about what we agree on again, which is that somebody like staying in, I assume Kylie meant like this angry, like state of like, this is not okay, like they're not okay, and I'm like staying in that angry pattern, I don't know, emotion, whatever that experience. I agree that that's definitely not like what therapy should be about at all whatsoever. The only reason why we might frame something that way is just to understand the imprint that left on the nervous system. So it's less about the stories themselves, the details of the stories, who we're pointing a finger at. That's all like very much a side point. And it's not really a side point, but I mean, in terms of therapy, it's a very real experience. It's a main point. But in terms of therapy, that experience left an imprint on your nervous system that is resulting in you adapting in a bunch of ways. One of those ways might be in therapy, you now have this part of you that needs to just blame your parents and not focus on how you feel. That might be a survival adaptation. So I could choose to say, well, don't talk that way. That just fuels your emotions, which is kind of what the way their parents talk to them. Don't be this way, be that way. I'm not going to do this something like that. That's not, I'm staying far away from something like that. I would rather go and say and slow them down and say, like, hey, I'm noticing there's a part of you that's really focused on how bad your parents were. They have all kinds of like assessments that are going on, judgments. It's coming up in all of our sessions. I'm really wondering what the role of that is here. Like, what would happen if that part that needs to do that, like, kind of like gave you a little space just to see how you feel about all these stories that you've told me, right? And now we can start to meet the part of them that actually was wounded and to give it the care that it didn't get and compassion that it didn't get. And maybe that part of them doesn't have to do that job anymore. And I can honor the job that it's doing, and it can be in our sessions. If it needs to come in at any time, it can come. But let's understand what the role of it is, because it's an adaptation. It's a symptom. It's helping the clients stay disconnected from themselves. It's too scary to go into the imprint of the nervous system, so they're going to keep that alive. So my approach would be to really just honor the whole experience, accept them in their whole experience, and also really try to, like, okay, and then what? And then what? And who was that one that got hurt by that parent? And where is she now? And what does she feel towards that parent? What happens when you go to your family and your father is parenting the way that you parented? Who's getting activated? Who's the one that's showing up there and getting dysregulated or whatever? That's the part of you that probably has been wounded. So let's see what we can do to help her. So I would try to get her to the same place of, like, how do we build the safety inside so that we can actually feel much, much better and also be connected to your whole self, because that's wholesomeness and trauma's fragmentation. And rather than keep these things fragmented, I want to bring cohesion, integration, and that's what brings the nervous system to regulate. When it's no longer fragmented, and we're able to integrate these experiences, that's regulation. So that's all I would say for that piece. And I totally agree that we don't want to keep a client stuck in this, like, intense emotional, like, their fault. I would definitely slow it down and say, I'm noticing that. Tell me about that. What is that all about?
Mm-hmm. But I love that. I love that we can both agree on so many things. It's really, it's it really highlights, where the differences are, and they're not as far apart as one may think. Hi, Lieba. If you could give a message out there to people who may be watching, whether they're thinking about going into therapy, or maybe they already are, or they've had some kind of experience, or maybe they feel marginalized in some kind of way, what would be a message that you would like for them to hear?
I would love for people to hear that no matter what you've been through, and no matter what Shadam says or whatever is going on, experiences are experiences. We all go through experiences that are varying levels of insane. So, you're not damaged in any way or special in your special in your badness, if that makes sense. Like, there's nothing worse about you for going through what you went through, and you have, like, total capacity to build for yourself the life you want. I know that can feel confusing, that can feel impossible, but it is absolutely possible. I'm not saying it's easy. I'm just saying it is possible. And sometimes figuring out what that is really, really tricky. That can be okay. But just know that it is very much attainable.
Thank you. Shaya?
Taking that in, it's so heartwarming.
Yeah, so, like, I feel so good just to hear those words and that tone. Really special. Thank you.
I'm, like, literally, like, just imagining those words entering anyone watching and, like, soothing, beautiful. So I would say, if I could say a few things, I think I want to speak to a lot of what we spoke about, and then if I could just maybe just extend it into how people might be experiencing therapy and close out like that. I think that if there's one thing that I would want humans, beautiful, incredible, amazing humans, to take from this conversation, it's that what we call symptoms and evidence, literature and stuff like that is not a defect. It's not something that's wrong with you. It's a survival adaptation that your nervous system had to do. And it's so loyal to you, like incredibly loyal to you, how it's got you to be able to get to where you are right now and to survive because you're precious. That's why. Because the nervous system, the brain, they know you have an neshama, it's pure, it's incredible, and they're going to find ways to protect you from getting that hurt again. And that's like, you know, the Sefer Torah goes behind, like, we have the curtain, and then we have the doors, and then we have the silver, and then we have the thing, and then we have the belt. There's layers and layers and layers and layers of protection, and they all don't need to go away. They don't need to go away. They actually protect something very, very precious. What we're looking to do is to see, do they need to? Sometimes we take out the Torah to read from it because it's beautiful. And we have to take away the protection. There's a time, there's a place that, and it could be unifying and connecting, right? So that's what we're doing in therapy, is not pathologizing and saying you can't be this way. Actually, you need to be this way because you're precious. But there's an extreme role that it's doing right now where it's stuck or at a past time, a past place, and it's still doing what it had to do, but it hasn't gotten updated. Like, and that update and will help you feel more connection, more love, which these words could be terrifying to you right now, and I totally want to validate that. But there's such a thing as love, connection, safety. It's a real thing. It's really real. It's real. It's a real thing. And you don't have to spend your life like coping mechanisms with that I had to form with trauma. I could actually rewire the connections and regulation where I now have so much more choice. Like, do I need to be protected right now? Can I engage in this experience, even if it's difficult or hard or challenging? Can I do that? So that's definitely what I want to say, is make sure that we know that we're not broken and we're adapted, and that all of this can change. I would also want to say that, unfortunately, this is no client's fault, but because of a lot of politics, this diagnosis of CPTSD is still not in the DSM. And therefore, not enough clinicians know about this. They're still going to try to link it with PTSD, and that's what we're going to try to do. But the treatment's completely different. And because of that, there's not enough training and not enough research and not enough funding. There's even a modality that is a CBT-esque like modality that's a bottom-up type of therapy, which goes into the nervous system, that it took 10 years to get funding on. 10 years, even though it's like CBT-ish, because it's very hard to measure human beings and capacity and complex cases. Clients who have dissociation, which is very common in CPTSD, many clients don't even know that they're dissociated, and there's many forms of dissociation. It's not just derealization and depersonalization where you're out of your body or you're watching yourself. Many, many, many forms. One of them is an example that we gave before of my parents are this and my parents are that. It's a form of keeping me awake. And those cases don't get into research studies because they're too complicated and they're too complex, right? And it's very, very hard to study. So I would just want to say that, like, I want to honor the experiences. I want to say that everyone's trying their best, but not enough people know about this stuff. And research is biased. They only study things that they want to study for a reason. If they study CPTSD, they're going to find that a whole lot of other diagnoses in the DSM are no longer relevant. A lot of medications that a lot of people make a lot of money on are no longer going to be something that we can classify as treating that. And it's also not going to be short-term treatment. Nobody says that CPTSD is short-term treatment unless you link it to PTSD. So there's a bias that we want to link CPTSD to PTSD so that we could get you in short-term treatment. But if you look at the research that is out there is some research out there. They've actually been trying to research this since the 1990s, but of course they won't get funding because who's going to fund it, right? But you will find that the treatment takes many, many years for a lot of clients. Who's going to want to fund that? Oh yeah, go stay in mental health treatment for many, many years. So we'd rather simplify it into symptoms and symptom reduction rather than like quality of life and look at it as a different type of diagnosis. That's not, oh, avoidance. Oh, you have avoidance. No. I don't just have avoidance. I have a whole lack of inherent safety and worthlessness that I'm dealing with. Go ahead and measure that. You know, people are not mice. They're not rats. They're very complex and they're complicated. And to study CPTSD is brutally difficult. And even though they are studying it, it's not something that's going to be so clear cut and it's complicated and complex. So they're not studying it for a reason.
I just wanted to add that CPTSD, as far as I'm understanding, is not included in the DSM for political reasons. It's not included because the research is not yet supporting the diagnosis, even standing on its own, and certainly for clinical utility, which is all things that they look extensively into. So I do think that's important just to clarify that it is a complicated issue. The PTSD field and the BPD field are very robust fields with a lot of research in how we assess, how we understand, how we treat. And so all those things get massive consideration. And so wouldn't want to oversimplify that.
And I want to thank Amudim for giving us a platform to talk about this in an honest way, where people could like finally feel like, oh wait, I make sense. Wait, so when I go to therapy and I can't talk, and my therapist is like, how am I going to help you if you don't talk? There's actually nothing wrong with me, even though they're the professional and I need them. Yeah, like maybe you're in a freeze, maybe your system collapsed because you're triggered by this relationship. So to me, you're coming to therapy at full capacity. You're at full capacity. You just walking in the door is full capacity. And don't believe what they train therapists that they shouldn't work harder than their clients. We're not buying into that. Therapists should work very, very hard to help you feel safe because you don't know how to do it yourself. And they're going to do that. And just lastly, in the same way, therapists are not so special. Can I just put this out there? I'm sorry. We're special because we're humans, but we're not like more special than somebody else because we're not healers. We're not here to we do something that makes you get better. What we actually do is just set up the conditions that your body does for itself, right? So in the same way that you get a cut or some kind of wound, as long as we don't get in the way, like suddenly your body knows how to get rid of this infection or whatever, and whatever it's called, heal the scars and whatever. Like emotions are the same thing, just you had no safety to access the parts of you that could actually help yourself. So the therapist's job is to be that safe, grounded, anchored, regulated presence to allow the natural way that you are. That you're bigger than yourself. You're connected to God. You're connected to a whole lot of things that are not traumatized. They're not. You just have no access to it, and the therapist just helps you get access to it. So I know it's like a thing, like, when we're young, we want our parents to be like these perfect people, and like that we go through that stage in development. Your therapist, we got issues. Don't worry. That's my closing statement.
Thank you, Shaya.
Yeah.
Thank you, Lieba. This was so informative, interesting. I feel like people out there heard two really different perspectives, but in some ways not so different. And I think people are going to gravitate to what pulls them more, what resonates more with their inner world, with their experience, with their process, maybe even where they're up to. Maybe they'll start here and then continue there. So thank you for being so clear, informative, and Mirza Shem will be able to help people along in this process just by having these kinds of dialogues together. Thank you so much. Thank you, everyone out there who's watching.
Thank you so much.